Good afternoon again. My name is Richie Lazaro. I don't know most of you, to be honest, so I'm introducing myself as a pathologist, previously in clinical practice, but 3 years ago I joined Roche. So I'm the regional pathologist for Roche Diagnostics in Asia Pacific. So I'm here to be the moderator and to introduce to you our speaker, who probably doesn't need any introduction, seeing how I see him interact with his skin pathologist friends. So Dr. Robert Rawson is a medical graduate of the Australian National University and achieved his FRCPA in 2016. He was appointed the Cameron Pathology Fellow at the Melanoma Institute Australia for 2016. After a year practicing in Darwin, he returned to Royal Prince Alfred Hospital in 2018 as a staff specialist. He is faculty member of the Melanoma Institute Australia and is currently completing a PhD in melanocytic pathology. So we welcome today Dr. Robert Rawson, who will speak to us on the role of PRAME immunohistochemistry in the diagnostic approach to melanocytic lesions.
Thanks very much for the opportunity to talk today. And today I'm talking about something which I've been grappling with for the last 2 or 3 years, and that's how I utilise PRAME immunohistochemistry in my diagnostic approach to melanocytic lesions. And I don't think I'm the only one that has this problem. Lots of my colleagues have had similar problems, and the amount of literature that's coming out, it seems to be about 5 publications every month that comes about PRAME immunohistochemistry in these lesions. So obviously other people are trying to get out how they see the immunohistochemistry of PRAME as useful. And also as part of our consultancy role we have at RPA, we're starting to get a fair amount of cases sent in from outside pathologists where the PRAME immunohistochemistry has at least formed part of the reason for the consultation, and the outside pathologist hasn't been certain about how to interpret the PRAME immunohistochemistry as in the context of the wider lesion. Now, I'm talking about one lesion, while the previous speaker spoke about a whole range of lesions, but I think PRAME is quite an interesting immunohistochemical stain, and I think pathologists are pretty mild-mannered people, but I've seen dermatopathologists get quite excited, and you see their pulse rising when you mention the word PRAME. So hopefully this will foster some good discussion. And I don't have all the answers. I can't promise you that you're going to know everything about how to utilise PRAME, because I'm still trying to figure it out in my own practice. And I'd love to hear other people's opinion at the end. So I'll briefly be talking about the history and context of PRAME and the immunohistochemistry of PRAME, then focus most of the time on the role in the assessment of cutaneous melanocytic lesions, and then finish with looking at other reasons that PRAME has been utilised and published upon. So PRAME stands for preferentially expressed antigen in melanoma. It's quite a suggestive term and gives you a good idea of how it's useful. It was first identified in 1997 from T-cell clones in patients with metastatic cutaneous melanoma, and PRAME mRNA was detected in both cutaneous and ocular melanomas and other variety of non-melanocytic tumours, which we'll talk about later on. Most benign tissues have very minimal to low or none PRAME mRNA expression, except the testis and a few other sites, and that's why it's in the category of a cancer testis antigen. And due to that profile, obviously, that is an attractive profile for the development of targeted therapies in melanoma and other malignancies, and there's several ongoing trials in that space. Now, how PRAME gene expression is regulated is not fully understood. However, it seems to work on the retinoic acid receptor pathway, and it inhibits that pathway, therefore inhibiting that pathway's ability to induce arrest, differentiation, and apoptosis. It's also, I think if you've been to any other the talk previously in the melanocytic breakout room, it's also been, mRNA expression at least, has been part of a risk stratification profile in ocular melanomas, or uveal melanomas, and a diagnostic assay in cutaneous melanomas. Now, I'd like to thank Richard Scolyer for these slides, which I think really illustrate why we need things like PRAME immunohistochemistry. That is because I think most of us as pathologists know that the vast majority of melanocytic tumours are readily identified as either benign or malignant quite quickly under histological examination of just an H&E section. However, there is this group in the middle which does form a smaller but significant and important group of patients, which are borderline lesions where we have a difficulty in making a diagnosis. And in that group, it's really quite poor inter-observer reproducibility. But I think this slide illustrates the types of lesions that you see in this group. Now, I think there are two distinct groups. There's one group where there is actually a diagnosis of a melanoma or a nevus. It's just very difficult to make. And that is either the wolf in sheep's clothing, that's a nevoid melanoma, or the sheep in wolf's clothing, that's an atypical nevus, such as a nevus of a special site, an irritated nevus, or a nevus in pregnancy, etc. However, as we've become to realise, and has been spoken about previously earlier today, there's a distinct group of intermediate lesions, now generally called melanocytomas in the literature, which show histological and molecular features between nevi and melanoma and appear to behave in a mostly benign fashion. They can go to local regional lymph nodes, but generally not beyond them. Now, the gold standard to assessing these difficult, or any melanocytic lesion, but particularly these difficult borderline cases, is the gold standard is really close clinical histological examination with close clinical correlation with that examination. Unfortunately, this gold standard I don't think is particularly gold. As I said, the inter-observer reproducibility in these lesions is really quite poor. But as we've sort of discovered the way that the melanomas develop and also nevi, we've developed a toolbox here of things that we can use in these cases. And there's a variety of things I've outlined there. There's different cytogenetic studies, mutation analysis, immunohistochemistry, and proteinomics. And just a couple of those that people we've used a bit more: comparative genomic hybridization, so whole genomic screening, chromosomal gains or losses. Generally, when there's minimal, that's usually in keeping with a nevus, and melanomas often have frequent of chromosomal gains or losses. Generally, the intermediate melanocytomas show intermediate features, which sometimes usually really don't help us, but they can on occasion. And through the use of CGH, FISH was developed, targeting specific probes in this space. These really do have quite good sensitivity and specificity in unambiguous lesions, sort of 80 to 90%. But when they become ambiguous or borderline, they really drop off, particularly for FISH. Sensitivities drop to around about sort of 40 to 50%. Now, these modalities, they're usually only found in larger centres. They can be costly and be quite time-consuming to be performed, and therefore aren't really realistic in everyday reporting. However, obviously, immunohistochemistry is converse. The converse is true in that it's quick, it's cheap, and we can turn it around, and it's actually widely available in pretty much every lab. And obviously, due to the clinical interest in PRAME as a target for treatment, immunohistochemistry of expression of PRAME was developed and assessed. And this is where it really first came to most pathologists' understanding. And when we saw the study, and that was back in 2018, it was done by Klaus Busum and his colleagues at Memorial Sloan Kettering. And it looked at PRAME expression in melanocytic tumours. And he looked at around about 400 different melanocytic tumours, all unequivocal diagnosis. So these weren't the ambiguous tumours. They were all definitely nevi or definitely melanoma. And they were a mixture of benign nevi, primary melanomas, metastasis with a smaller amount of solar lentigo and sun-exposed skin. Now, importantly, I think at the start we'll talk about how it's been scored or interpreted since this very first publication, and it really hasn't changed since then. And that was the percentage of nuclei staining positive, ranging from 0 to 4+, taken roughly quartiles, so the 4+ being greater than 75% of nuclei staining positive, which was also called diffuse staining. Now, interestingly, the intensity is not part of that equation. It's only pretty much if it was positive or not. Some people have published using an intensity score as well, but the majority of people have published just on that sort of quartile cutoffs. And this is not from Klaus's paper, but this is from another paper which occurred a few years later. This looked at metastatic melanoma. And this is an example of some of the staining profiles. And A and D, I think, are really readily identified as A being a negative stain and D being a diffuse 4+ staining. It's B and C, which I have troubles with, and that, unfortunately, that's often what I find in these ambiguous lesions, that looking at C there, it's a heterogeneous kind of pattern. Some are intense, some are a bit weaker. How many of those cells are staining positive? I think that's quite difficult to actually estimate, and I think there would be really quite poor inter-observer reproducibility on B and C. Probably C is thought to be around about 3+, but I wonder if more than 75% of them are staining, but some of them are just are weak, and B is sort of 1 to 2+. But I think if something looks like D, I think that's obviously a strong positive staining, but it's B and C which I have difficulties with, and I'll talk about that later. But the vast majority of ones that in the paper that Klaus published were like this, strong diffuse staining in both the in situ and the associated invasive melanoma. So the results he found were really very promising in these unambiguous lesions. So greater than 80% of all melanomas he looked at stained positive diffusely for PRAME, so more than 75% of nuclei staining positive. And that rose even to greater than 90% when the desmoplastic melanomas were taken out. And from this point on, it was thought that desmoplastic melanomas wasn't a particularly good use, and everyone else generally published not looking at desmoplastic melanomas. Roughly the same amount of melanoma in situ stained positive, more than 90%. I mean, look at the subtypes which weren't desmoplastic, they were all roughly around about 90% of them staining positive, so really quite a high sensitivity. And when a melanoma was seen to arise in a nevus, it was only the melanoma which stained positive. And I think this is one of the actual great uses of PRAME, is when you have a morphological benign lesion and a more worrying lesion arising in it. If the benign lesion's negative and the worrying lesion's positive, I think that's extra confidence that's a melanoma arising in the nevus. Roughly the same amount of metastatic melanomas stained positive, 4+ positive, and there was good concordance between matched primary and metastatic melanomas. And these are just a couple of examples. So this was a melanoma arising in the nevus, and the nevus is on the left, and the expansile growth of the melanoma on the right. And it was only, as I said, the melanoma which stained diffusely positive, while the nevus was completely negative. And conversely, looking at nevi, why it was so promising was that nevi really showed minimal to no staining in the vast majority of cases. One dysplastic nevus showed 2+ staining, and one junctional Spitz nevus in a young child was diffusely staining. And in the non-melanocytic skin, only scattered cells really stained positive. And that was, I suppose, potentially useful in looking at lentigo malignum, particularly looking at margins for that, which is presumed why they did it. And this is just an example of some of the nevi they showed in their paper. The top is just a benign nevus, which showed some sort of 1+ staining occasional cells, staining positive in the junctional or in the superficial dermal component. The second panel there is a dysplastic nevus with 1 to 2+ staining, and the bottom panel was that one Spitz nevus which showed diffuse staining. And this is just the sun-exposed skin. The top panel, obviously, the H&E, the middle panel, the SOX10, and the bottom panel, the PRAME. And I've replicated this many times. While it seems to be very good, and when you just pick a BCC up and stain it with PRAME, it doesn't really stain hardly anything in the epidermis, just occasional scattered small nuclei staining positive there. And since this time, many people have replicated similar findings in unambiguous lesions as the Busam group did. And we were one of those groups. I suppose we're all trying to figure out if it was too good to be true and set our own thresholds, and many groups sort of show that in non-desmoplastic melanomas it really had quite a high sensitivity and specificity in unambiguous lesions. And then this is just one of those cases which was published, I think, 1 or 2 years ago, which started to look at those ambiguous lesions, things such as atypical nevi up the top, melanocytomas at the bottom, or nevoid melanomas in the middle there. And once again, you can see, whilst they were small numbers, it was still quite a promising immunohistochemistry stain in cases such as that. But I come back to the point of what is a positive stain, and this is one of my biggest problems I face when interpreting PRAME. As I said, I can look at D and think, yes, that's positive. It's when something comes back like C that I'm uncertain of how to actually interpret that in the settings of looking at the lesion. And in my interpretation, I probably would have thought that was 3+. And over my just anecdotal practice, I was noting that more than what Klaus was saying was staining in that manner. We're staining in that sort of heterogeneous pattern around about 50 to 75% of cells, and sort of D was only happening in around about half the melanomas I was seeing. So we looked at this. We did immunofluorescent multiplex staining of both, combining a SOX10 in combination with a PRAME stain, and had a computer count it and set thresholds. And only about 40% of the melanomas we looked at were staining diffusely positive with 4+. Whilst if you included the 3+ staining, that really brought it up to what the earlier publications had found. And other people have found this as well, I think probably due to their everyday reporting, that probably a lot of melanomas are staining 3+ positive as well, and it's not quite as sensitive, that 4+ staining, as what potentially may have been published earlier. Once again, it's important that a negative PRAME does not dissuade you from a diagnosis of melanoma. That's a really important take-home message. And as I said, this is not helpful in desmoplastic melanoma. We usually looked at a whole range of desmoplastic melanomas in our study. The only time PRAME stained positive was in the really high-grade variant, where you weren't struggling to make the diagnosis. None of the really subtle neurofibroma ones, really, they showed no staining at all. So then we come to these ambiguous lesions, which I suppose is why we want the stain and why we want to use the stain. And ambiguous lesions come under many categories. Obviously, the melanocytoma categories, the spitzoid ones, the deep penetrating nevus-like areas, the blue kinds. But also, as I mentioned, it's those cases where they're actually the nevoid melanoma or the atypical nevi. And obviously, Klaus had the jump on everyone and published in this area and looked at 110 ambiguous cases around a whole range of different diagnoses. A bit of a busy slide, but these are just the tables he published, and he really showed quite good agreement between the cytogenetic results, either FISH or SMP array, and PRAME immunohistochemistry. And as you can see from the top table, this is comparing the two, split out from 4 plus PRAME and less than 4 plus PRAME. As you can see that in the top line, when FISH was negative, only very few cases of that showed PRAME diffuse staining. Or conversely, when there was cytogenetic positive results indicating possible melanoma, I suppose there was less discordance in that category. The majority of cases, as I mentioned, were actually cytogenetic positive results where there was non-diffuse staining, where there were occasional cases where there was diffuse staining with PRAME and negative cytogenetic results, but the overall interpretation of the lesion was still that of a melanoma. 2 spitzoid lesions were PRAME negative, showed positive cytogenetic results, but they were favoured overall to be atypical Spitz tumours or melanocytomas. There's just a couple of examples that he used. Obviously, a nevoid melanoma with a positive FISH result and completely negative staining for PRAME. And this is an atypical Spitz tumour, which was strongly diffusely PRAME positive and sort of intermediate results on SMP array. And this is another case they used with a nevoid melanoma arising within a pre-existing nevus, and the FISH results from this weren't positive to indicate melanoma. And this is the only other case which has looked at sort of cytogenetic results or molecular results and how it compares to PRAME. And that was the Western Australian group through Ben Wood and Nathan Harvey as first author, which was published at the end of last year. And they showed significantly less correlation between PRAME, and they looked at FISH only in an instance of a differential diagnosis of a thin melanoma and a dysplastic nevus. As you can see there, whilst the table has been flipped, which makes it confusing to us, compare it to the previous table, you can see even in the FISH positive cases, there was only sort of roughly a third of cases which were positive, which were negative, but 2/3 were positive. So significantly less agreement between them, and therefore I think PRAME can't be used as a surrogate marker for FISH. But the idea that still there could be a useful ancillary test in these lesions. And this is just 2 nevoid melanomas from their study, both with positive FISH results. One stained strongly diffusely positive for PRAME, the other was completely negative for PRAME. And this was another paper that came out recently, assessing consensus expert opinion on favour benign, favour malignant, and compared that to PRAME immunohistochemistry on ambiguous lesions. And they really showed a very high specificity and sensitivity in expert opinion. Only a few of these cases had FISH results. With that specificity of 92% and a sensitivity of 93 to 94%. So really quite promising from their point of view. These are just a couple of the cases that I've seen over the last 2 weeks, actually. So this was from a 36-year-old female on her left flank, obviously a compound lesion, a dermal component which is nevoid. The junctional component is slightly more worrying, even at low power. It's a bit ill-defined. In another section showed a bit more spitzoid morphology and starting to get a bit more atypical with some near confluence and upward spread. This was noted to be a changing lesion clinically. And as you can see, the SOX10, that sort of maps up with the junctional component, which looked more worrying, and really quite confident in some upward spread, and probably more was seen on the SOX10, as you often find, than the H&E detected. And this was the PRAME stain, and whilst negative, whilst it's weak, the vast majority of those junctional cells were positive, whilst the dermal component was completely negative. And I think the differential diagnosis on a case such as this is this an irritated compound dysplastic nevus, or is this a subtle melanoma in situ arising within a nevus? And I think from my assessment of the H&E, the worrying clinical history, and now the findings of PRAME, particularly because the dermal component's negative and the junctional component's positive, I was concerned this is a melanoma in situ, and I favoured that in my report. This is another case of a young female, a 20-year-old, once again a compound lesion, a nevoid dermal component which looks reasonably banal, and the junctional component which, well, I suppose on higher power I was slightly more concerned with. There was some irritation, and there was this lentiginous component with some early upward spread, but I was reasonably happy that the dermal component was benign. You see the SOX10 stain on the left. Whilst there was more prominent on the SOX10 stain, it was still rather well demarcated. But on the PRAME stain, that only stains sort of roughly around about 50% of the cells in that junctional component. And whilst I probably couldn't completely exclude a melanoma in situ, my morphological assessment of that lesion, combined with the PRAME staining not being florid and not really extending beyond where I thought it should be, I favour this to be an irritated compound dysplastic nevus. And I suppose my pre-test probability was that this was going to be benign. I think that's really important, that I was looking for confirmation that this was benign, which is why I looked at the PRAME stain. Another case we looked at just yesterday, so this was a 35-year-old female of a case in the calf which was taken out because they had a diagnosis of melanoma in situ elsewhere. And it's really difficult to see at low power, quite a nevoid silhouette. What looks to be the junctional component nested and lentiginous, but not particularly worrying on H&E, and the dermal component I think looks slightly atypical, but there's good maturation, single cell dispersion, no expansile growth and no mitoses. The SOX10 stain, I think the junctional component's a lot more florid there than I had sort of thought it would be, but it's still that's what it showed. And then so a PRAME stain was done. I presume it was done by the outside pathologist because they were worried this was a melanoma in situ arising within a nevus. And the PRAME stain lit up everything. So it lit up the dermal component and it lit up the junctional component. And as Richard Scollier said, if that's a melanoma, I'm done. So I don't think that is a melanoma. I think that's a PRAME-positive nevus. And so I think, therefore, the H&E assessment is really important on how you approach the PRAME staining. And I agreed. I thought this was a nevus every day of the week. Whilst the junctional components are slightly increased, I didn't think there was enough evidence of melanoma in situ compared to the clinical history, which wasn't particularly worrying in this case. So this is just a brief summary of that first part I talked about. I think it's really important that PRAME has to be put in the clinical context in which it arises. You need to have your H&E impression, and the clinical correlation is still your gold standard. And I think PRAME can be used as an ancillary tool, but it's really to give you confidence, I think, about where your initial, I suppose, pre-test diagnosis probably is. And it can support a diagnosis of melanoma positive or nevi if it's negative. It can be useful, I think, in partial biopsies, and I'll show you a nail biopsy later on where it was quite a disrupted biopsy and there was only a very focal lesion which showed some atypical features, and it pushed us to at least make sure there was a complete excision done of the lesion due to the PRAME staining. As I mentioned, it is a cheap, rapid turnaround, widely available tool. And whilst it can't be used interchangeably with fish, I think it can be used on its own as an ancillary test in some situations. Where it can be quite useful, I think, is in interpreting a Breslow thickness on these melanoma arising from a nevus, which can be difficult to actually interpret, where you figure out where the melanoma starts and stops and the nevus begins. And as I mentioned, I think it's particularly useful when you've got a lesion arising within a pre-existing lesion, which you think is probably a melanoma, and you use PRAME to show that differential staining. As I mentioned, a not insignificant number of melanoma are PRAME negative or patchy. Nevi can show some positive staining, and they can show some diffuse staining, so you have to be careful when interpreting them. As I said, it's not really useful in desmoplastic melanomas, and it's not recommended in that space. There's limited data in melanocytomas, although that definite intermediate group. And as I mentioned, my main difficulty in using this immunomarker is those stains which are 3+, diffuse, heterogeneous, so it's diffuse but heterogeneous and sort of weak and patchy in areas. And I find it really difficult to know what to make of them, and I generally revert back to my H&E impression rather than putting too much importance on PRAME in a case such as that. Now, going on to other areas where PRAME has been recommended in the literature, I think this is a useful use of PRAME, and that is looking at difficult nodal deposits of melanocytic cells. And I spoke in the melanoma breakout room about how this can be a differential diagnosis in a sentinel lymph node biopsy. There's been 2 studies I found which looked at it. All nodal nevi were PRAME negative. However, when looking at melanomas, they were all predominantly positive to strong diffusely positive. Importantly, if you're going to use PRAME in this setting, you should test the primary for PRAME, as if the primary is not PRAME positive, generally the metastasis will not be PRAME positive. So if you're going to use it, you should be testing the primary as well. And this is an example from one of the papers showing on the top a nodal nevus with melanase staining strongly in the middle to outline where the lesion is, and completely negative PRAME staining. The bottom is the deposit of melanoma with prominent melanophages, and the PRAME just stains the nuclei of the melanoma and not the melanophages. And as I just mentioned, it's really important to understand that not all metastatic deposits of melanoma are PRAME positive, so you really have to look at it in the context of its other features, its anatomical location within the lymph node, and other features such as what the primary looks like. And nodal low nevi have not been assessed with PRAME to date. Now, this comes to probably one of the more controversial areas which I've been asked about previously, and that's using PRAME in assessment of margins of melanoma in situ. And Klaus was onto it in his first paper, and he looked at it in 10 cases, but he didn't actually specify which type of melanoma in situ he was looking at, as far as I could tell. And so he assessed 10 cases in terms of H&E, SOX10, and also PRAME staining. And there was vast concordance across all three methods of where the margin would be in that space. However, it's in lentigo maligna, I think, which is where people are sort of looking for extra help in trying to figure out where these lesions start and stop, compared to the sun-exposed skin of the surrounding epidermis. And I think anyone that reports melanomas, we struggle with this every day. Oh, sorry, that previous one, that was just an example of Klaus's paper where you could pretty much draw a line down about a third of the way in from the left about where the margins started and stopped on each different modality. So this study, which was published late last year, looked at lentigo maligna in situ and assessed it PRAME as for the margin and how it compared with H&E. And they looked at 32 cases of involved margins by both H&E and PRAME. 3 cases which were H&E involved but not involved by PRAME. It was only less than a millimetre difference between the two, and 2 cases where it was reversed, where PRAME was positive at the margin and H&E was not. It was only less than 1 millimetre was the difference. And looking at 35 cases where the PRAME or H&E was not involved, the vast majority, as you can see, 14 plus 17, what's that? 31, if I'm not mistaken. That there is almost good concordance, less than a millimetre difference between the two modalities, whilst a few cases there was a greater degree of discrepancy. And I often get asked, do I use this in this space? As you can see, here from this, there was a good correlation and no tendency to either over or estimate the margin by using the PRAME method. So it's one of the more frequent questions I get asked is, do I use PRAME for assessment, particularly lentigo maligna in situ disease? And I think it comes back to the natural history of this disease, and this is a very slow-growing lesion and a slow rate of metastasis to an invasive melanoma. I think Scott Menzies showed it was about 3% per year that lentigo malignas progress to invasive disease. And they frequently occur on cosmetically sensitive sites. Now, I think on H&E you can tell if the margin's floridly involved with melanoma in situ of lentigo maligna type. So you don't need to do it on that occasion. But it's the occasion where people are contemplating using it, where you get scattered PRAME cells at the margin. Do you call that a positive margin? And I don't think that's an appropriate use, personally, of PRAME. These things are so slow growing. I think the more appropriate way to use is not use PRAME in that situation, is to monitor the patient closely, and if obviously the lesion grows or comes back, you can biopsy it then. I think you possibly could be doing a disservice to the patient if you rebiopsy on a scattered positive PRAME cells, which might take 10 to 20 years to develop into a lentigo maligna in situ disease. But some people might have a different opinion. I'd love to hear that, and this kind of use that some people have put forward for use of PRAME. Just briefly coming to the end of different uses, people have looked at it beyond cutaneous melanoma in mucosal, subungual and conjunctival sites and have found similar findings in unambiguous lesions. Hasn't really particularly been looked at in those ambiguous lesions in these sites yet. And this is an example of this biopsy we got from the nail bed recently, and it was distorted and difficult to interpret. However, there were some concerning areas. On the left, there was this unusual junctional component, which was really quite small, sort of less than a millimetre across, with some nest and lentiginous cells with some upward spread and some atypia, but not much of a lymphocytic infiltrate below it. And this dermal component, which is around about 2 millimetres away, which was more hyperchromatic and epithelioid. Both of those cells stained positive with SOX10. And so a PRAME stain was performed, and it stained both of those components positive. Am I certain that's a melanoma? I'm not, just due to the limited amount of tissue that's present, but I think that PRAME is concerning along with the histological features. And I am concerned that is a melanoma, and I think definitely that needs to be re-excised. Now finally, talking about PRAME in other malignant tumours, and as I mentioned, it's been outlined, it's been found in many other carcinomas, sarcomas, and hematolymphoid tumours. Interesting, I think last month or the month before, that someone published in the Journal of Pathology about cutaneous carcinomas, and it was found to be positive in some SECs, BCCs, and adnexal tumours. And so people often have started it, not often, but in our department are starting to use PRAME in undifferentiated or dedifferentiated malignancies, doing a PRAME stain, wondering if it could be a dedifferentiated or undifferentiated melanoma. But just looking at that staining profile, I don't know if there's no melanocytic differentiation found by any other means or molecular features, I'm not sure our PRAME positivity is enough to make a diagnosis of an undifferentiated melanoma. Although I suppose it could be a possibility if they're looking to get access to immunotherapy, that might give you some to make a comment. If the oncologist is trying to get access to immunotherapy, the possibility is a dedifferentiated melanoma, but I don't use it in this setting. And just a final point, that clear cell sarcomas in a small study, none of them were found to be PRAME positive, and so we can possibly use that as an ancillary test before going on to more formal FISH testing. And I think that's all I really want to talk about today, so I'd like to thank you for your attention, but I would really love to hear about anyone else in the audience that is passionate about this area or has found it's helped them out or really let them down in certain cases. So I'd hand it over to the room. Thank you.